Got a good last session set up. We're going to talk about something that really affects most of us, especially anybody that's taking call out there on the front lines. Talk a little bit about some fractures. But first, it's my pleasure to present the winner of the Basil Boyd Memorial Resident Award. I think we had 3 excellent papers presented by the guys. And as I mentioned earlier, we received a total of 12 abstracts from all over the Southeast, from the University of Tennessee at the Camel Clinic, Medical University of South Carolina, University of North Carolina, Duke, 3 from Georgia Regents University, and 1 from the Medical College of Georgia. So really the whole Southeast was represented, and I think we really had excellent papers presented. After a lot of discussion, it's my pleasure to present the award to William Mook. And Will, if you're here, come on up. Now I'd like to introduce my partner, Pat Connor. Pat's going to talk to us today about the new trends in management of clavicle fractures.
Thanks, Shad. I'd like to take this opportunity, I'm sure all of us will at different times, to thank Shad and Natty for their extraordinary efforts in putting together a great meeting. So thank you very much. I was just speaking to Dr. Ghazi, who's here, a wonderful man who's retired, who's here today, and I said, would you ever imagine 20 years ago fixing a clavicle fracture? And he said, absolutely not, never. But things have evolved, and it's interesting how they've evolved even over the course of my career. So I'm just going to review some of the reasons why and where we are now. We've all seen this. It's more common than we think. We get that phone call from our buddies on a Saturday morning at 8:45 in the morning, and that's never a good call. I have no conflicts of interest related to this. So what's the big deal about clavicle fractures? They all do fine. They all heal. And so why in the world should we spend 15 minutes talking about it? Well, if the existing literature is very clear with one thing, and that is they don't all do well with non-operative treatment. So it's incumbent upon all of us to try to figure out who may do well and who may not do well and see if we can change the natural history. And looking at a couple of the studies, this back in 1998, almost 250 consecutive clavicle fractures, patient-based outcome assessment, 15% non-union, and 31% unsatisfactory clinical results, pain, plexus symptoms, functional limitations. And you can see there's a discrepancy between the percentage of non-unions and the percentage of those doing poorly. So non-unions aren't the only thing we need to look at. And a factor associated with a poor result was initial shortening greater than or equal to 2 centimeters. A prospective study a few years later, again, almost 250 consecutive clavicle fractures, almost 50% of patients with sequela from their clavicle fracture 9 years later. But again, that discrepancy, only 7% of them had obvious non-unions, but these are radiographic non-unions and not CT-based non-unions. The strongest predictor for adverse result was no bony contact, and comminuted fractures with the transverse fragment, as seen here, was a predictor for a poor result as well. And this is what has been called under B there at the bottom, the Z fracture, the Z-type fracture, where that comminution is vertical relative to the orientation of the normal clavicle. This is a extremely large study published in the journal in 2004 trying to estimate the risk of non-union. Again, these are radiographic non-unions, slightly less than 5% risk of non-union, and increased incidence with advancing age, female gender, no contact on the initial x-ray, presence of comminution, and then a follow-up study that was just published earlier this year from the same group showed that those that were smokers, they stratified smokers, and that was also statistically significant as far as having bad results. So this is some data from their study, and it's way too busy to look at, but if we just look at those fractures that are displaced and comminuted, and look at age and gender. And, and one can see, particularly in the female gender category, 25, 35, 45, the older we get, particularly women, have a really high incidence of having non-unions from this problem. Mike McKee, who's from Canada, has essentially rewritten our understanding of clavicle fractures. This was one of his earlier studies in 1999 that looked at patient-based outcome measurements and showed that there were major residual impairments consistent with some of the other studies I mentioned in about 100 consecutive clavicle fractures. So you'd think, well, holy cow, nobody does well with a clavicle fracture. Well, not so fast, surgeons, because there is some disagreement in our literature. Norquist showed that only 1 of 7 non-unions had a poor result, and even those that had permanent shortening did pretty well. A couple other studies couldn't demonstrate a relationship between shortening and poor shoulder function. 90% of about 100 consecutive patients in that Peterson study showed that patients were doing fine, not having follow-up. And then a subsequent study showed that neither angulation nor shortening caused shoulder function. And so what's the deal? Why the contradictions? Well, the bottom line is that it's become clear, not only in this, but every other aspect of orthopedics, that patient-based outcome measures reveal different answers than surgeon-based or radiographic-based outcome measures do. So if we ask the surgeon how their patients are doing, the surgeon said, oh, they're doing great. If we look at the x-rays look great. But if we actually ask the patients, and if we do so in a prospective manner, then they may not be doing so well. And so this is a study that essentially, like I said, rewrote the way we handle clavicle fractures. Is a prospective, randomized, multi-center study on operative versus non-operative treatment of clavicle fractures. And those patients that had operative treatment had statistically better results in functional scores, return to activities, time to healing, number of non-unions, symptomatic malunions, and patient satisfaction. And then they did a follow-up study, the same group in 2012, and showed that the minimum 2-year follow-up results were essentially the same. And so based on that, we have these evolving indications for surgery in our general patient population being the degree of displacement or shortening greater than or equal to 2 centimeters, or with no contact to completely displaced fractures, high energy or comminuted fractures, particularly that with a Z fracture where that central portion is vertical, and also consideration of some patient-specific factors, age, gender, smokers, and maybe even contact athletes. And so what about contact athletes? Well, there have never been any studies that have looked at that patient population and clavicle fractures and how best to treat them. And so Bobby Morgan, Mike Honig, Chip Banks, and myself, we looked back at the NFL experience over the course of the last 5 years, and essentially the goal was to take a very specific patient population and see if that mirrored what our experience was in our general patient population. And it was published a few years ago. It was a review of 5 years through our NFL injury surveillance system, which is our database. And essentially, we looked at non-displaced and displaced clavicle fractures and stratified them that way. Those that were non-displaced, all of them healed, all of them did fine. Average time to healing was about 7 weeks. And there were no re-injuries, no refractures, and all players returned to play in the NFL. So the non-displaced clavicle fractures kind of off the table as far as changing what we do. But there were 13 fractures over the course of that 5-year period that were displaced and or comminuted. 6 of those 13 had acute surgical management. Of those, all of them healed. There were no refractures, no complications. They healed at an average of 8 weeks, and 3 of those 6 returned to play in the same season, again at an average of 8 weeks postoperatively. Half plating and half intramedullary fixation, which we'll talk about. 7 of those 13 were treated non-operatively. 3 of them healed, 4 of them didn't heal, or they, quote, refractured, all within a year of their initial injury. So if you look at those numbers, which obviously are smaller numbers, but essentially 21% of all the fractures didn't do well, and 31% of the displaced and comminuted fractures didn't do well, which is essentially identical to what our experience is in the lay population. And most concerning from a player standpoint is that of those 4 out of 7 that either didn't heal or refractured, the average amount of time that they lost from their job was 1.5 years. And 3 of the 4 missed the entire subsequent season after their initial clavicle fracture. And in a sport where the average duration of a career is 3.5 years, that's a real big pill to swallow for a clavicle fracture. So our summary was that it may be reasonable to consider acute surgical management of completely displaced clavicle fractures to have a predictable clinical course, avoid missing time the subsequent season, and may even allow a safe return in the same season if the injury is early in the year. One thing we don't know is what may be the risk of refracture. None of those have refractured. None to my knowledge in the NFL have refractured around the plate, but we know that can be a problem, like in forearm fractures. So in looking at surgical techniques, there's a whole slew of them, but primarily plating and intramedullary fixation are the most common. Plating has been the gold standard. Complications often are related to the plate selection and technical issues. We know that you don't want to use small tubular plates. The pre-contoured, thicker plates are better than recon plates for acute fractures, and you don't want to use recon plates for non-unions. Joe Ionati did a study and colleagues on the plate location and the type of plate. It was a biomechanical study and showed that the ideal place to place the plate was superior on the clavicle rather than anterior, which is the way some of the trauma surgeons have advocated. And then they compared the different types of plates and showed that the construct superior was the best, and also the 3.5 LCDC plate, the thicker plate, was statistically better from a biomechanical standpoint. So a recon plate placed anteriorly might end up with a result such as this, is what their take-home message was, which obviously we want to avoid. So the newer anatomic plates have not yet been as extensively studied, but clearly offer some advantages with fixation, the locking plates, as well as minimizing hardware prominence. But this isn't a new concept. There's a study back in 1978. 20 out of 20 from plating a clavicle had good results back in, again, 1978. This is a 1992 article, 131 operations on clavicle fractures. Very good results, very few pseudoarthroses, and good clinical and radiographic results. Mike McKee's study, complications, he had 3 infections out of 67 that he managed non-operatively, let him heal, and then ultimately took out the hardware, and they all did well. And he had 2 out of the 67, or 3%, important number, 3% that had their hardware removed. And there were no catastrophic complications, no subclavian artery complications or bad problems. But it's important that we understand the plate doesn't do it by itself. There's some technical pearls. Need to make sure there's a precise approach through the delta trapezial fascia. Fix it like all other fractures with compressive and anatomic fixation. Avoiding prominence of the plate. Again, I prefer the pre-contoured anatomic plates. Being kind to the periosteum and the soft tissues, get a nice thick fascial repair on the way out, and I personally don't like the concept of percutaneous plates because sometimes you can end up with some bad complications such as this. Changing gears, intramedullary fixation. There's several different options, but essentially making a small incision to anatomically reduce the fracture and then putting a rod through the clavicle. As shown here, here's an example on the top left, a Z-type fracture, a couple intraoperative photos, and then the final photo below can get anatomic fixation with good bone stock. The advantage, obviously, it's a smaller surgery, less dissection, no long-term hardware because you reoperate on all of them and take the hardware out. It's not ideal for comminuted fractures because there's not as much inherent stability of the fracture. And that bolt in the back can be symptomatic in thin patients and can have some wound problems back there. So that can be a relative problem. Here's an example of someone that had a problem with wound healing in the back, but typically that goes away once you take the pin out. But the complication rates vary widely in the literature from 5 to 50%. So there's some variables there, particularly the reoperation, which can be a concern. As I mentioned, just the plate doesn't do it by itself, but neither does the pin. There's some technical considerations with that. Primarily, not only getting a good anatomic reduction, making sure that the fracture itself is amenable to intramedullary fixation, but make sure that that pin doesn't exit too high laterally. because there's a force going inferiorly there, and you want to make sure that you're in good bone on the lateral clavicle. So a few case examples. Here's essentially a weekend warrior, just an example of that a Z comminuted fracture that did very well with plating. Here's a NASCAR driver that I actually would talk to him about initially treating non-operatively, but as I look closer, there's this piece of comminuted bone subcutaneous outside of the trap, and so what that means is it went outside the trap and then came back, and so at the time of surgery there was interposed trapezius muscle between those fragments. Plus, he had to go back to work and wear the Hans device, and trying to wear that Hans device over a displaced clavicle fracture was a problem. So he had surgery, everything went fine. He missed 1 week of work and was back driving in about 10 days. It's a patient had a severe mountain biking accident. Just a FYI, we plated his clavicle, but as you can see, there was also an associated AC separation. So I had to address the AC separation at the same time. So don't lose the force because of all the trees sometimes, because those could be together. Here's a markedly displaced transverse fracture that I thought was just too far away. Oftentimes has interposed soft tissue, but a good option for the intramedullary fixation here because there's good stability of the fracture. This is an NFL running back from several years back. Talked to him about all the pros and cons, did his surgery, and after about 3 days, he wanted to know why we didn't treat all clavicle fractures this way. Here's a patient that had an atrophic non-union, 4 previous surgeries, one of which was an infection that required an intercalary bone graft and trying to get the right length from one side to the other. Sometimes these are more complicated, but can result in really good results. Here's a 15-year-old boy. Interestingly, that Z fragment or vertical fragment, I put A and B to show the position of the bone. Well, once the muscles wake up, there's shortening of the fracture. So essentially, the proximal part of that piece flipped around and clearly had to be repositioned. So I made a small incision and used the intramedullary device, and it did quite well. So my personal preference is to use intramedullary fixation in young people with good periosteum, great healing potential, and with minimal comminution. Plates in older folks like myself, more severe fractures, and those that a second surgery may be less desirable, like a professional athlete. And of course, non-unions, I use plating. An interesting study, in consideration of Obamacare, well, what about the cost? You'd think this costs a lot, but there was a study that was done just this year that showed the overall cost showed a savings of a little bit more than $5,000 per patient in the operative group. And the reason with that is the amount of time lost from being in the workforce, because you don't lose much time if you have surgery. You have surgery Wednesday or Thursday, and you're back to work on Monday. Excuse me. A couple comments about lateral clavicle fractures. It's about 10 to 15% of all clavicle fractures with associated injury of the corticoclavicular ligaments. Dr. Neer said that there's about a third of them that were problematic, and subsequent studies have shown the same. Not all of them do poorly, but certainly the displaced fractures, consideration to fixation should be given. There's a lot of different treatment options. Plates, coracoid fixation with supplemental fixation has been very popular, and a lot of other creative techniques. There's these new anatomic plates that have the locking screws that I would strongly recommend. That they work great, and also strongly consider supplemental coracoid sling fixation to address a corticoclavicular ligament in a load-sharing capacity as shown there, which really works nicely. Here's a patient that I put clavicular sling fixation just with some sutures, and it brought it down so nicely I didn't even use a plate, and she did fine. Some will use different types of suture buttons. I personally have no experience with this. I worry a little bit about the fixation on the bone, but some have had some success with it. And there's been some other creative techniques. Dr. Hammond has described this technique down in the lower right, which he's really proud of, but no, just joking. There is this hook plate, which you all may be familiar with. It's been shown that it can be successful, although 100% of patients have to have that big plate removed, and you can only have 90 degrees of elevation until it is removed, and you don't remove it till 4 months or so. Ultimately, this study showed that it can work well, but they stated in their paper that they only had 4 complications, but as I read the paper, they had a malunion, a non-union, wound breakdown, 2 failures of fixations, 1 stress fracture, and 3 near misses with severe acromial erosion. So the potential of having about 40% complication is quite high. So I personally wouldn't recommend this, but it may be helpful in a salvage situation. This is one last important point is, does timing matter? Mike McKee also looked at this as well, and he looked at immediate versus delayed fixation and essentially showed that there's really not much of a difference. So the only marginal difference was in constant scores and endurance strength with acute fractures, but otherwise healing, strength of flexion, abduction, dash scores, long-term pain, etc., essentially no differences. So I kind of leave it up to the patients and say, we can do it now or we can do it later. So in summary, although displaced mid-third clavicle fractures can be managed successfully, clearly based on patient-based outcomes, the displaced clavicle fracture results are less than ideal. These factors that we talked about, specifically those patient-specific factors with age, gender, smokers, and maybe contact athletes, we may want to consider operative management in these higher risk patients. Thank you.
Thank you, Pat. Our next topic is Dr. Natty Hammond speaking to us about proximal humerus fractures. Repair, replace, or reverse?
Okay, thanks, Shad. Okay, in this talk, I'm going to talk about a wide variation of severity of injuries, beginning with fairly simple proximal humerus fractures and then getting into more complicated cases. I have no disclosures. Well, proximal humerus fractures now represent the 3rd most common fracture in elderly patients. We're seeing that not only is the number of patients that are reaching that elderly group is growing, but these patients are becoming much more active. They want to do more. About 1 in 5 of these patients will have a fracture they may consider surgery for, and we're going to see a growing demand for the on-call orthopedist to manage these patients. Before we kind of go into how these patients were definitively treated, I think it's important to talk about a few preoperative things that really help you end up with that final decision. Patient factors are extremely important, and for me, age is a huge predictor of what type of management I'm going to select for the patient. Their activity level, whether this is the dominant or non-dominant arm, and their overall medical condition. We're going to also look at some of these other fracture factors before we can come up to a final conclusion of how to treat them. Understanding the fracture is absolutely critical, and so a lot of times patients will present to you with emergency room x-rays that are essentially worthless. They don't give you any information, and they really can't help you make a decision on how to treat the patient. So you should really not tolerate poor x-rays and repeat them in your office if you need to. I think 3 x-rays are mandatory, and that's an AP, a true AP, and an axillary view. Here's a standard AP x-ray. Here's a true AP in the plane of the scapula. And this gives you a nice look at the reduction of the greater tuberosity to the humeral head, and I think this is probably my most important x-ray in deciding treatment. And finally, the axillary view. If you don't feel like you have a good understanding of the fracture, or really these x-rays don't give you enough information to make a decision, then a CT scan can be very helpful. So here's a good example of a patient that had a AP and a scapular Y, which is the routine set of x-rays that emergency departments will get. And you can see this looks like a fairly benign injury. This is a younger guy that had an electrocution injury. You can see that CT scan shows it to be much more severe. He has a posterior locked fracture dislocation. And so this could have been easily identified if you would have had an axillary radiograph. And so make sure that you get all the proper radiographs so you can properly diagnose the injury. We still use the classification first described by Codman, later described by Dr. Neer, that uses essentially a 4-part fracture scheme using the humeral head and the greater and lesser tuberosities in the humeral shaft. But there's other things you have to consider too, more than how many parts the fracture is. What's the blood supply to the humeral head? We now know that the blood supply to the humeral head is not just from the anterior vessels, it's really an anastomosis of both the anterior and the posterior vasculature. An important thing that we've realized is if the humeral head still has a small metaphyseal extension on it, and that metaphyseal extension is still in relation to the humeral shaft, that's a good prognosis that the blood supply is preserved. If they don't have that metaphyseal extension or it's very displaced, there's a good chance that head is not going to survive. Bone quality is also important, and J.P. Warner has shown that the thickness of the diaphysis of the humerus is directly related to the patient's overall bone mineral density. And so this is important if you're considering or contemplating an ORIF, in that this can help you make a decision whether you think this is going to be a reasonable option for your patient. So here's my algorithm for treating proximal humerus fractures in 2013. I will repair a fracture using a locking plate construct in 2- and 3-part fractures and younger patients with 4-part fractures. I'm not going to talk about using humeral nails. That's something that's used in certain parts of the world routinely for fracture fixation, and I don't have much experience with it, and I just don't have much comments on it. Replacement surgery is something, when I say replace, I mean standard hemiarthroplasty, is something I really reserve to a 4-part fracture in a younger patient, where I can't get a good reduction or good stability of the fracture with a plate and screw construct. Those are the ones where I'll use a hemiarthroplasty. And overall, I'd say the utilization is decreasing with hemiarthroplasty, really for 2 reasons. One, we push the indications for ORIF, and we push the indications for reverse. So that the third choice for me would be reverse shoulder arthroplasty. And I'd use that in an elderly patient with a 3- or 4-part fracture. And sometimes we push the age limit on that as well. So we're going to go through some x-rays. We'll kind of decide on what the fracture is, some patient information, and then decide which one of these 3 we've selected. So this is a 38-year-old gentleman with a 2-part fracture. You can see he's got pretty significant comminution of the metaphysis. He's the wine guy at Trader Joe's. He's the one that gives you all the wine taste testing there. And so he, very active, likes to do the CrossFit and things like that. So we elected to, you could probably treat this non-operatively as well, but based on his age and that comminution of the metaphysis, we elected to treat it surgically with repair. So 2-part fracture, proximal humeral head locking plate construct. And these have really revolutionized the way we manage proximal humerus fractures. That x-ray on the right is something that was not all that uncommon to see before these plates were brought into the market. These plates allow you to use multiple locking screws spread into the humeral head, and pull out of the screws out of the humeral head is extremely rare. Sometimes you'll see screws pull out of the shaft, but very rarely will you see loss of fixation in the humeral head. What you can see is subsidence of the humeral head onto the screws, or screws that were inadvertently placed too long. The clinical results really have shown that these plates have changed the way our patients do. The overall clinical results before and after these plate designs have been introduced into orthopedics has drastically changed clinical outcomes. Here's another example. This patient's a little bit older, 55, and obese female with this fracture pattern. And you can see that the humeral head is valgus impacted, meaning it's tilted up too much, facing too superior, and she has a large greater tuberosity fracture. So I'd call this a valgus impacted 3-part fracture. And you can see the relationship to the humeral head and the tuberosity is not good. And so this is something that needs to be treated surgically. And so an ORIF can work well for these patients. In this example, you should really place the plate to get it directly over that tuberosity to give yourself nice security over that bony fragment. So just like Dr. Sperling mentioned about tuberosities and hemiarthroplasty, if you remember one thing from this talk, it's tuberosity reduction is key. And that's not only for ORIF, I would say that's also true for hemiarthroplasty and for reverse as well. With older patients, these tuberosities will probably be very fragmented and weak bone, and so getting good suture fixation through the rotator cuff and then incorporating that into the plate and screw construct is the way to manage the tuberosities. But getting the tuberosities reduced anatomically and getting them to heal in proper position is really the key to success with proximal humerus fractures in general. All right, here's another example. This is a 52-year-old female physician in Charlotte that had this proximal humerus fracture, and you can see that things don't look so good. She's got a lot of comminution in there. The humeral head is tilted way out medially. There's a lot of discontinuity between the head and the shaft. You can see the CT confirms that, maybe even to be a head split component. So a 52-year-old female, non-dominant arm, you know, not really, in my mind, not really a good option actually to treat this. I ended up doing a hemiarthroplasty. Sometimes I'll try reduction in the operating room, and if I don't feel like things are coming together too well, I'll just go ahead and proceed with the hemiarthroplasty. And so you can see that her tuberosities were repaired, and we got lucky in that she healed her tuberosities, and that's her final x-ray on the right. but that is not always the case. I borrowed this slide from one of my mentors, and this is honestly what you usually see with these. Just like Dr. Sperling mentioned, tuberosity resorption for hemiarthroplasty after fracture is exceedingly common, unfortunately, because what happens is the tuberosity is resorbed. As you can see, that humeral head starts to superiorly migrate, and the patients have global rotator cuff dysfunction and a really poor clinical outcome. And that's one of the reasons why we don't like to do the surgery and try and push the indications for both ORIF and hemiarthroplasty, is because you can feel like you do everything right in these cases, and you still end up with a bad result. So it can be very frustrating. All right, so that kind of leads us into this next one. This is an 88-year-old female, dominant arm, pretty active female, and she presents with this fracture. And remember, we talked about that medial metaphyseal hinge. You can see that humeral head is very displaced from the shaft and probably doesn't have much blood supply left to it. 88 years old, really for me, there's not much of a question in what to do for these cases. This is a reverse shoulder arthroplasty in 2013. And so you can see that the tuberosities, I try really hard to get them reduced and trying to get them to heal in good position. You can see that's our final x-ray on the right. And if you can get them to heal well, you can have a good outcome. But the thing about reverse is you can really get a good outcome even if the tuberosities don't heal. And so it really levels the playing field across the board, that if you can get the reverse performed and get the components in good position, patients will have good pain relief, and they'll have pretty good forward elevation. The tuberosities will just be icing on the cake, because the tuberosities will give you the rotational function abilities that is nice to have with reverse, and certainly you would like to have it, but it doesn't, if you don't get it, it's not a dismal failure like you see with hemiarthroplasty. So the clinical evidence and studies are still coming out to justify use of reverse over hemiarthroplasty for patients, but we are starting to see that the reverse does outperform hemiarthroplasty for acute management of fractures. Okay, here's another case. This is a guy that had a fall and an electrocution injury and has this posterior fracture dislocation. And so this is an interesting fracture in that the back part of the humeral head is actually still intact with the shaft. He just has a lot of this articular impaction anteriorly. So for him, we decided to repair it, and we actually went outside the box a little bit and just disimpacted his articular surface and used some headless screws and some bone graft substitute under the head. So sometimes with these, you can think outside the box, and this is where CT can really help you plan these surgeries. This is a 56-year-old guy, seizure disorder, bilateral shoulder fracture dislocations, and so this is a disaster. So this kind of guy comes in with shoulders that looks like this, and younger guy, but there's not really a good option to fix these. When you have the humeral head that's broken off the shaft and dislocated off the back on both sides, he gets a hemiarthroplasty. For me, that's still a little too young with both sides involved. I don't think that reverse arthroplasty is the right option for him. And so I find this surgery to be one of the most difficult surgeries I do is hemiarthroplasty for fracture, because you have to get the height right of the humeral stem, and then you have to get the tuberosity secured enough to start early range of motion. And so we can, this is one where you can get a good result, but it really just relies on those tuberosities. Okay, this is a 40-some-year-old guy that was a band director, had a fall down an embankment. And so if you look at this x-ray, you can see his humeral head's obviously dislocated, tuberosity's off, but look how much bone is left on that humeral head. This is not something you can just take that undo a replacement or a hemi. So this is one you need to fix. And so big surgery requires a long plate, but ORIF is the answer for those types of fractures. All right, this is the last one. This is a 72-year-old gentleman, fall on his boat, retired, non-dominant arm. And you can see that the fracture has lost a lot of the relationship to the head, and CT scan does show some intra-articular splitting of the humeral head. And so reverse shoulder arthroplasty is the answer for him in my practice. And you can see the tuberosity was repaired, and sometimes you can almost shingle it on the humeral shaft to have the shaft and the tuberosity overlap a little bit, and that may give you a little bit more predictable bone-to-bone healing. And so with the tuberosities healed, you can not only get that elevation, but you can also get that external rotation ability as well, which you can see in the middle image there. So locking plate fixation and reverse replacement, for me, has revolutionized the management of proximal humerus fractures. You have to consider both the fracture and the patient characteristics when weighing all your treatment options. Thank you.
The last talk in this session is going to be about distal humerus fractures. In my disclosure, I do some consultant work with Tournier. It does not have any bearing on this talk. So the typical time I see this kind of fracture is on a week when the OR schedule is already slammed and this walks in the door, and where do you put this thing? Because as anybody who takes care of these fractures know, this is very labor-intensive fracture. This is going to take a couple of hours in the OR, and so it's just one of those Murphy's Law thing. Inevitably, this shows up when you least want it. The goal is to be able to get results that look like this, and this is the kind of mess that we aim to avoid, which unfortunately we've all seen before. Distal humerus fractures make up about 2% of all fractures. They make up about 1/3 of fractures around the elbow. And really, you see two separate classes of patients that have these fractures, either young patients that have high energy trauma injuries, or elderly patients that are fairly low demand and have poor bone quality. And it makes a tremendous difference which class these patients fit into as far as how you manage them. Initial evaluation, obviously a history and mechanism of injury. It's very important to take off the splint and do a thorough physical examination. Soft tissue status is important. Neurovascular status is important in these fractures. The radial nerve, especially in some of the extra-articular Holstein-Lewis fractures that we'll see, you want to be able to document the status beforehand. Radiographic classification we're going to look at, and for any of these complex fractures around the elbow, I will always get a CT scan with 3D reconstructions. I think it's important to know what the size and the orientation of the fragments are before you go in there. The typical standard AO classification of distal humerus fractures really breaks these fractures into three groups. The Class A fractures are extra-articular, and these fractures still can be very challenging, as we'll see in a couple of the cases, because they're very unstable, and especially the patients that have the big arm with the big varus stress on it, it is exceedingly difficult to brace these appropriately and make them stable from a non-operative standpoint. The type B fractures are unicondylar fractures, or involve only one of the columns. These also have the fractures that involve the capitellum or the trochlea we'll touch on. And then really the most challenging or the most complicated of these fractures are the T-type or intercondylar fractures, where there's an actual split or disruption of the joint. I think it's important to think about the column concept. When we look at these fractures, the elbow is really made up of three columns, the articular segment being one, the medial condyle, and the lateral condyle fragments. And this is the picture that you want to restore surgically. Treatment options vary. I've had a couple lately of these in frail, medically ill, older patients who we've managed with brief trials of immobilization and early range of motion, and surprisingly, they can do fine. But by far and away, the majority of these, as long as the patient is healthy, we're going to either fix or replace. The first class of fractures are the type A extra-articular fractures, these so-called Holstein-Lewis fracture. Majority of these fractures are unstable, and the fractures want to collapse into varus. And as pointed out below, the location down near the elbow joint makes these very difficult to brace without immobilizing somebody in a long arm cast or splint. And as we all know, the longer you immobilize the elbow for these fractures to heal, the worse problems you're going to have with stiffness. You always want to document the status of the radial nerve before deciding on a treatment approach. And for me, the operative management of these is ORIF with plate fixation. We approach these fractures posteriorly. You can either decide to do a triceps splitting approach or a triceps sparing approach. I would say by far and away, I would try to preserve the triceps and work around it if at all possible. I think patients recover faster functionally with their triceps not split. And contoured plates have really helped us in the ability to fix these fractures. This plate has a contour that wraps down around the lateral condyle, so it allows you to get some fixation distally on these fractures without being close to or near the olecranon fossa and limiting their range of motion. The triceps sparing approach was described by Gerwin et al. In JBJS in 1996, and I really like this approach. You find the posterior cutaneous branch of the radial nerve. It sits back near the intermuscular septum, and once you find that, you can use that branch and follow it up until you locate the mark where it comes off the main radial nerve branch. So once you find and locate the radial nerve, it's pretty straightforward. That's the biggest thing we worry about is radial nerve when we're exposing these fractures. Once the nerve's located, you can elevate the triceps. You can release both above and below the nerve. Gets the triceps a little bit more excursion. And when they looked at the difference in approach, the triceps split approach was only able to expose up to about the radial nerve. You can't get quite as high as you can with this approach. If you are able to locate the nerve and work both above and below the nerve, you can really expose, as on the picture on the right, almost all the way up to the surgical neck. The next classification of distal humeral fractures is these type B fractures. And the ones that we probably see more commonly are these capitellum shear fractures. These fractures have varying size. They can extend all the way across the joint surface, and some even can involve this whole trochlear surface of the joint. These fractures obviously have to be fixed. You have to restore the integrity of the articular surface. You approach these through a direct lateral approach. I typically use the Coker interval. I've learned a lot from Pat about these as far as other options for fixation. I will either use headless compression screws, or Pat's taught me that the terminally threaded K-wire is great in some of these cases where you may not have room to put bigger screws in. You can get some terminally threaded K-wires that you get solid fixation and just cut them off. And so I will not hesitate to do that as well. Fixation-wise, people describe either an anterior to posterior approach, or you can put the screws in from posterior to anterior. I typically try to approach them from the front, although those fractures that really come across the medial side, it's really hard to get there anteriorly from a lateral approach. So I think you have to kind of look at the fracture, look at the CT ahead of time, and decide what direction that you want to go. It's also crucial in these to assess these patients for ligamentous injury and instability of the elbow, because that's something that you definitely want to address at the time of fixation. And then the last class are the intra-articular distal humeral fractures. And these are where both columns are disrupted, the articular surface is split. A lot of these fractures have central comminution in the articular surface, and these are the fractures that require either fixation or arthroplasty. For ORIF, plate fixation remains the gold standard. It's really helped us having pre-contoured locking plate designs available to us for these fractures. And the thinking these days has really changed from, initially we were doing 90-90 perpendicular plate constructs. Sean O'Driscoll at the Mayo Clinic has a passion for these fractures and has really done a tremendous amount of work on how we approach them now. And Dr. O'Driscoll has described parallel plating. I think that's where a lot of people have gone in fixation for these. Plate configuration, does it really matter whether you put the plates at 90-90 or parallel? Probably not. For most fractures in younger patients that have good bone quality and minimal comminution, probably it doesn't matter what configuration you use. However, I think the parallel plate configuration may afford improved fixation, better biomechanical strength in these complex comminuted fractures and poor bone quality. And there are certainly pitfalls of inadequate fixation. So if you're going to fix these fractures, you have to fix them rigidly and securely. The goal of fixing these fractures is to get them moving early. So whatever you decide to use for fixation, it has to be stable enough to let them start moving. The advantages of parallel plating, it's been shown that torsional displacement of a perpendicular plate is about twice what it is in parallel plate configurations. The stability is significantly higher in axial compression and external rotation with parallel plating as opposed to perpendicular plating. And the other factor is many of the activities of daily living that patients perform are activities where the arm has a significant varus gravitational force pulling on it. So by potentially putting that plate directly lateral, you can combat some of those varus stresses that can lead to failure. The surgical approach, these fractures are approached posteriorly. I use a lateral position. Some people prefer a prone position. You have to make sure you have adequate exposure on these fractures to be able to get proximally enough for your exposure. I typically expose and find the ulnar nerve on every case and then transpose them at the end. It's a choice whether you transpose it, but I think getting the nerve out of the way prevents some problems with late ulnar nerve symptoms. Olecranon osteotomy by far and away is the most accepted way to address these articular fractures. There's almost no other way to get down low enough into the articular surface to fix them. And there are a number of different guides that you can use now to pre-drill before you make the osteotomy, things that make it easier at the end of the case to fix back your osteotomy. There are some folks who prefer transverse osteotomy. I still use a standard chevron osteotomy. And even with the triceps sparing approach to this, it's almost impossible to see the articular surface. Articular reduction is typically where we start with these fractures. Find all the comminuted fragments. There's a lot of comminution centrally, and the articular surface is reduced and provisionally fixed with K-wires. The next step is to secure the distal segment and the columns to the shaft. And medial and lateral plates are placed. You can put initial fixation with cortical screws to bring the plates down to the shaft, and then place a number of locking screws into the distal segment. And then I think importantly, as Dr. O'Driscoll describes, you really want to assure that you're getting good compression between the distal fragments and the shaft. So by using a reduction clamp, you can compress one side, fix it in, change the clamp over to the other side, compress it, and fix it in place. So you're getting good compression at that supracondylar level. The results of ORIF, distal humeral fractures, have been fairly well described. Holdsworth et al. Presented a series in 1990. They had 57 patients with 3-year follow-up. All of these were type C intra-articular split fractures. They reported 76% subjective good to excellent results by patients. There was an average range of motion of 115 degrees. Similar study, Helfet and Schmeling reviewed their type C fractures, 75% good to excellent results. They did note some complications including heterotopic ossification at about 4% in their series. And then a couple of series with the newer parallel plate fixations also describe overwhelmingly good results, although it is noted in the Anthwall study about 16% of ulnar nerve complications. There certainly are complications that can be associated with these injuries. And I think some of that comes back to the nature of the injury itself. Ulnar neuropathy can be reported about in as high as 10%. So that, in my mind, it's a reason to transpose. Non-unions are infrequent. When they do happen, they're mostly in the supracondylar level. So we feel like we're pretty straightforward about how to fix these. What about this patient? So this is a 68-year-old female who fell while gardening. And if you look at this fracture, these really low fractures are very difficult to get fixation into that distal piece. So these are the patients that we are leaning more towards total elbow arthroplasty for. And it's been very well documented in the literature that for these particular older patients with these osteoporotic bone and low fractures, the total elbows do better than the ORIF group. The indications for a total elbow, patient have to be medically cleared for surgery. They have to be patients that are fairly low physical demand. Patients should be willing to accept a 10-pound weight limit for life once they have the replacement done. These are fractures not suitable for ORIF or presence of arthritis. For me, there's not really a true age cutoff, but I think out there most people think of 70 and above lean towards replacement. Dr. Frankel reported probably the best series of this in 2003. They looked at patients greater than 65. They compared patients that were treated ORIF versus total elbow. It was non-randomized. There were 12 patients in each group. The total elbow patients had shorter OR times, shorter hospital stays, and rehab time. The results, the total elbow patients reported 11 excellent, 1 good, as opposed to the ORF patients that had 4 excellents, 4 goods, and 3 poors, which led to ultimately 3 revisions. Mike McKee has also looked at a series of patients that were randomized to either ORIF or total elbow. Interestingly, in those 42 patients, they had 2 deaths, and 5 patients ended up crossing over from the ORIF group to the total elbow group intraoperatively. At each time interval, the MEP score and DASH scores were better for the total elbow patients, and at 2-year follow-up, reoperations, there were 12% in the total elbow group and 27% in the ORIF group. One more thing to touch on is distal humeral hemiarthroplasty. This is a operation that I think is only for a very specific indication. And these would be patients who have higher physical demands. They have fractures that are really not suitable for ORIF. Maybe patients in that 60 to 70 range, but that are more active and you're worried about doing a total elbow on. These hemiarthroplasties require that you have intact condyle fragments. So in a lot of these hemiarthroplasty cases, you have to do some type of plate fixation on the condyles and put the hemiarthroplasty in to restore the articular surface. There really are no good long-term studies on this, and so I think we'll learn more about this in the future. So in summary, distal humerus fractures I think are complex and difficult for all of us. I think we have to adhere to the true principles of anatomic reduction, stable fixation, and early range of motion, and definitely consider arthroplasty options for elderly patients with poor bone quality. Thank you. Do we have John Sperling come up to the panel as well? I'd like to open up the session to any questions that you have for the panelists. We also have a couple of cases if nobody has any questions. So hopefully these x-rays show up okay. This first case is a 62-year-old female who fell while out gardening. She has kind of this fracture similar to Natty showed at valgus impacted fracture with a displaced greater tuberosity fragment. 62, very active. Thoughts about what direction you would go with her, Natty?
How displaced is the tuberosity? I can't see it too well.
You can't see it very well. The tuberosity is probably at least a centimeter
Okay.
high and displaced.
Well, for me, that would meet an indication for open reduction terminal fixation. Some would maybe attempt a percutaneous reduction with percutaneous tamping up of the humeral head with screws and pins used. I think that has limited benefit, and I don't feel like causing too much morbidity making a skin incision in an adultopectoral approach, which essentially doesn't cut or damage any muscle. I think it's a pretty elegant exposure, and slipping a plate on there, if it's well contoured and placed correctly, really doesn't have any, I think, long-term implications at all. So I would do a standard open reduction terminal fixation using a locking plate. Just the two things that I would want to do is make sure I get the head properly reduced. And if you get to these early enough, that's easy. If you get to it late, it's hard. And the other thing is I would want to make sure the tuberosity is in good position before you put the plate down. If you're happy where the head is and then the tuberosity is off and you already have your plate on, you're going to be kind of caught there.
Absolutely. Pat or John, any takers for closed reduction perc pinning in fracture like this?
I don't have much experience with that. How about for the rest of the panel?
No, I wouldn't do a percutaneous pinning. What I have done is what Natty said, and that is just through a couple of arthroscopic portals elevated up and use like an arthroscopic cannula to pack bone graft, cancellous bone graft through that arthroscopic cannula, and the defect that's left laterally. But it's been shown in the literature and also my own personal experience that doing that in someone with osteopenia with poor bone doesn't work very well. So as Natty said, there's a very small window of patients, a little bit higher energy, a guy who falls off some scaffolding at work or better bone quality, where you can just put a dare up there and lift it up with good bone quality, bone graft under. I think the key to understanding is that the tuberosities aren't displaced here. What's displaced is the head that's down. You bring the tuberosity up anatomically, and the head up anatomically, and the tuberosity is just sitting there perfect. And so only in the case where you've got really good bone quality, which it doesn't appear this is, would I do that small incision, essentially a percutaneous equivalent, if you will.
Well, this is exactly what we did. I think the other point I think Natty touched on as well is in these fractures with tuberosity involvement, it's important to put some heavy sutures around your tuberosity fragments. And you can secure the sutures either through, most of the plate systems have holes you can secure them down to, but being able to reinforce the stability of the tuberosities to the plate gives me a little bit better feeling about moving these patients earlier.
It looks good, Shab. I probably would have put some more screws in the head.
The more screws you put in there, then you can't tell the reduction. You continue to make sure the reduction, we can see it. This case I put on here just especially for Dr. Sperling. This is a 65-year-old lady who owns her own ranch and had this revision hemi done about 9 years ago. Had been doing well, ranching. She reported her shoulder was great beforehand. Was bucked off a horse and comes in with this set of x-rays here.
So it almost looks like it's a transverse fracture at the tip or close to that. So there's three types. Type A is a fracture that extends proximally. Type B is typically a transverse fracture at the tip. And type C is a distal fracture. So the distal ones, a pure distal fracture, we tend to treat non-operatively. The A's as well. These tend to be bad actors when you have a almost transverse fracture at the tip. In our experience, a significant rate of going on to non-union. What I tell these poor people when I see them is that with operative intervention, the time it takes this fracture to heal is 2/3 of a year, and with non-operative, almost the same. So they're going down a long road one way or the other. So this is, and it does compromise their long-term outcome.
Absolutely. I think Dr. Sperling hit it right on the head. For this particular fracture, this transverse fracture, I have not had any good success with bracing them. I think it just sort of prolongs their misery. I think the options from an operative standpoint of fixing this, you can either select the option to fix them if the stem is well fixed, or I think you can also consider revision. Natty, if you're going to operate on this fracture, what direction would you go?
Well, I feel pretty strongly about this fracture that I think it would do very poorly without surgery. I don't think these have any capacity to heal. I think when there's cement down there, the bone doesn't get their correct blood supply, it doesn't get the right fracture callus, it just does not heal. So I think this patient certainly needs surgery or they're on their way to osteoarthrosis. I would fix this if the stem is stable and there's reasonable bone quality around the stem proximally. I would fix it with a plate and screw construct. And I would not use cables around the top. I would put screws anterior and posterior to the stem. But I'd use a very long plate. It goes from the shoulder to the elbow.
Shane, I think probably the one thing that would make me decide one way or the other is the answer to one simple question, and that is, how was your shoulder doing before you fell? And if someone's 9 years out from a hemi and they're doing great, they're riding a horse and they're very functional and they had 140 degrees of forward elevation, then I'd fix it for sure. But if she has not had, it's a non-dominant shoulder, she hadn't had an ability to lift it up in 9 years, then I would revise it to a reverse, and she should do quite well.
Right. Well, that was the part that I left out on you is, although she was ranching, she reported over the last couple of years that her shoulder just had not been doing as well as it had been initially. And so we elected to revise her, and we don't have any more images.
I would say the one other thing, and Chris Owens, one of your fellows now, did a great job of looking up our experience at Mayo of long stem components, and I will tell you, I try to avoid those like the plague. So for me, we have a number of people now coming in with long stem cemented components being put in on the primary setting, and that's a bad problem. When they fracture distally by the elbow, there's not much bone there. I've seen them where all the condyles are filled with cement. So I would just try to avoid long stems if at all possible. If they get infected, they fracture, anything like that. And this is what I would do. I'd go for a long stem here, but on a primary setting, try to avoid it. Sure.
Well, this is what I did. We elected to revise her. We used a long stem just to try and bypass her fracture, and we used a tibial allograft strut with cerclage, and she's about 1.5 years out now and doing very well. But
That looks great.
certainly it's a challenging operation, no question about it.
Looks really good.
That one didn't show up very well. Skip to the next slide. So this lady is a 76-year-old who came in with bilateral locked posterior fracture dislocations. The left side had minimal reverse heel sacs, was closed reduced, but this was her worst side. So Natty, what direction would you go in this?
I mean, really all you had to tell me is 76 and broken, and I'm probably going to just go ahead and do a reverse. So,
Pat, reverse right off the bat for this?
Yeah, yes. I've got two comments. One, in these bilateral posterior fracture dislocations, I've had a few experiences where one, it sounds like the other one was non-operative, but both of them were operative. One not so bad, the other really bad. I always go to the one that's really bad first, and I've used on several occasions, I've used the humeral head as autogenous bone graft to put over in the one that's not so bad that you could fix one and replace the other. And we wrote that up several years back. And so that's just something to think about. Go with the worst one first that you know you're going to replace. Save that bone for bone graft, and you don't have to take it from the hip. And the other thing that I was going to mention as far as hemiarthroplasty for proximal humerus fracture, it's been shown in the literature that the factors associated with poor results are age greater than 70, female gender, and the more severe fracture types. My experience has been there's one other, and that is obesity.
Yeah.
I cannot do a hemiarthroplasty for a proximal humerus fracture in a heavy woman and have her arm get up here. I think it's just there's so many forces across the shoulder. It's been your experience, John, or others, but in a heavy set person, particularly a heavy set female, I'm more inclined to go to the reverse earlier.
one thing I would want to mention about whenever you have a patient, then maybe not so much this one with posterior dislocation, but a lot of times you can see elderly patients with anterior fracture dislocations, and there is a high subset of those patients that will have an axillary nerve palsy. And I think doing a acute reverse in a patient with an axillary nerve palsy is a bad idea. I think the prognosis for them is good in that they'll recover their nerve, but I would lean more toward a hemiarthroplasty. And so you really have to look carefully for that, or you won't pick it up.
Well, I elected to do a hemiarthroplasty on this case, and just to show that, again, to reiterate what Natty's talk showed, I was really happy with my hemi. I thought, wow, that looks great. I got the tuberosity fixed back securely. It's great. We're giving everybody high fives all around. First couple months, she's doing well, but then all of a sudden, tuberosity starts to resorb, and she comes in with 30 degrees of elevation, pseudoparalysis, and pain. So she ended up getting revised to a reverse, and fortunately, you have a bailout, but more and more often, and I think in the literature bears it out, even well-done hemiarthroplasties have a difficult time getting back a good functional recovery. So we think long and hard about just going straight to reverse on these patients. Any questions or comments, Jason?
Yeah, I was just hoping you guys could go over how you judge the height of your humeral prosthesis in a displaced forepart for a reverse.
It's a difficult, I think it's a difficult thing. A lot of times I try to judge it off of the medial calcar, and I know there's some techniques looking at, bicipital groove. I typically, for these, I'm going to try and judge off of that calcar fragment medially. I don't know if anybody else has any comment.
John, how do you do that?
Yeah, I try to do the same. I mean, it's difficult to do, though. There's no doubt about it. And I think this is probably one of the most common revisions in my practice, is the hemi with tuberosity resorbed and go to reverse. Very, very common. It used to be hemi to reverse for cuff-yard arthropathy, but most people now go right to reverse. So this is a very common revision. It looks beautiful what you did. Looks just right.
The way I do that, Sheldon, is most of the reverse implants have X number of height options, and let's say there's 7 different options in whatever implant you're using. What you don't want to do is you don't want to put it so low that you put the biggest spacer in there and it's unstable. You also don't want to put it so high that you put the smallest spacer in there and it's too tight and you can't reduce it. And so what I do is I put the middle one, whatever, so number 4 if you have 7, and I trial that and find out, put some tension on the deltoid and trial it to where there's good tension on the deltoid, and I see how proud it is, and I mark it, and that's where I'll cement my implant. And then you've got options above it and below it, so you haven't painted yourself out of a room, if you will, and so you have different options, and so that's worked pretty well. You just don't want to be on one extreme or the other and have your hands tied.
Great. I want to thank you guys very much. Can you show the last set of slides, please? So that's the program for today. I just wanted to, again, thank everybody for this excellent attendance. It's been great. I think we've had some very good discussion points. I hope everybody got a lot out of it. I want to take a couple minutes to thank our sponsors. This really, truly would not be possible, this type of an event, without our sponsors. And our platinum sponsors, Zimmer of the Carolinas, our gold sponsors, Smith & Nephew and Tournier, and our silver sponsors, Arthritis, Biomed Sports Medicine, Carolinas Healthcare Foundation, DePuy Synthes, DJL Global, Exactech, and Lima Corporate, as well as our bronze sponsors. We greatly appreciate all of the support. Dr. Preventure had to leave to catch his plane, but once again, I'd just like to thank you, John, for being here. It's been amazing to be able to interact with both you and Matt, and we really, truly appreciate you coming.
Thank you very much.